I think we've lost them, Riley. I don't know what's happened there.
Riley, you're still on mute.
Oh, sorry. I'm back. Okay. Yeah, I'm just trying to find it myself, but there was a question somewhere there, but I think, yeah, if you could maybe just touch on those protein requirements, if there's any questions around that, that'd be good. I'm sure you might cover what I need to know.
Okay.
Physical activity, weight change, energy.
Okay, so
Jessie has joined as well.
oh, lovely. Hi, welcome, Jessie. Good morning.
Good morning.
I'm just going to answer a question for Riley, and then we'll begin shortly. So daily protein requirements for overweight and obese individuals, 0.8 to 1. Did you have any comment around that before we move on? Daily amounts of 1 to 1.2 have been suggested. There are other references that will say as much as 1.5. We've elected to go on 8 to 1.2 of adjusted body weight. So traditional recommendation for protein intake is 0.8 grams per kilogram body weight a day for adults of all ages. It's currently under discussion for older adults. And Aspen recommends up to 1.5 grams for older adults. I would certainly be leaning to the upper end of the range that we've suggested. And, you know, I wouldn't say that there is any issue with going higher than that, particularly in an older individual. And if there are problems in the individual with chronic disease, comorbidities, of course, where the energy and protein requirements may be elevated, then you are certainly going to bump that up. So daily amounts 1.2 to 1.5 been suggested for older individuals with acute and chronic illness, and even up to 2 grams per kilogram for those with chronic conditions, severe and chronic conditions or malnutrition. Anyway, we have elected to go with 0.8 to 1 in this instance. And that means that he would be having 68 to 85 grams of protein per kilogram per day. And if we use the midpoint of his BMI, then it would be 74. Remember, we calculated that, Riley? 74 times 0.8 to 1, so it's 59 to 74. And I would definitely be recommending the upper end of that, so 74 grams a day. Now, if his exercise regime changes, for example, this is a very individual, very specific thing. If he changes his exercise, if his state of health changes by the next time you review him, then of course you're going to make that adjustment and you're going to correct his diet accordingly. So he might decide that he's going to do an hour of weight training, strengthening exercises every day. You're going to need to bump up his protein significantly to accommodate that. Does that answer your question, Riley?
Yeah, that was definitely a part of it that I wanted to get some clarity on. But do you reckon I could steal a little bit more time and just go to 1.3? And there is a question that's on working out the total protein in grams. So it says multiply the average servings per day by protein per serving, and that's in 1.3, sorry, activity, evaluating food servings.
Oh, this is food analysis. You're talking about the dietary analysis?
Yes, yeah.
Okay, all right. Well, okay.
There's a few.
We might need to come to that. That kind of keen to get going. It's 9:05, so keen to get going for Jessie's sake on the.
Yep.
On that. Yeah, we can certainly come to that question. So just so that I'm clear, you're talking about this activity and you're talking about how to calculate the protein content of food.
Yeah, exactly. Yeah.
All right.
Going off the those serving sizes.
Yes, definitely. That's definitely a Ready Reckoner question. Okay, we will come to that. Now, how do you want to do this, Riley? Do you want to tune in say half an hour when we're ready to address that kind of thing, or do you want to stay with us?
Yeah, I'll stay.
Or do you'll stay with us? Okay.
Yep.
Cool. All right. So I think it might just be the two of you this morning, which is lovely. That's good. Let's get going. So Jessie, have you had an opportunity to read through the case?
Not yet, sorry.
Okay. Have you been on the website very much before now?
No.
Okay. All right. So I'll give you a quick introduction to the case and the overview of the website.
Yep. Thank you.
So did you buy a hard copy of the toolkit?
No.
Okay. In that case, you'll need the toolkit here.
Yep.
The toolkit, and the one you want to use is the Ready Reckoner toolkit. All right. And that gives you a lot of the detailed information that you'll require to answer the activities in your case.
Okay.
Cases are all set up in a similar fashion. We begin with the welcome page, which I think you could read at your leisure and watch the videos at your leisure, and it will explain the content of the case. We then have the learning outcomes, again, read at your leisure. The perspective, which is a scientific, it's a little literature review. Very important that you read that before you begin your case. And every case has a perspective. Some of them have as many as 6 perspectives, 7 perspectives, depending on the comorbidities of the patient. In this case, we only have one literature review, which is hyperlinked here, and you'll be able to read through the background information to the clinical condition at hand, adult weight management. The mind map is a complex overview of the clinical terms, the terms and codes from the nutrition care process and terminology that are linked to this condition. More about that later. The resources are all of those resources that we would strongly recommend you begin reading to get an understanding of the background literature into this clinical condition. And there's probably about 3 hours of reading there. And then we have the story. So this is where we're starting today. And Jessie, if you do have time to go back and review those various aspects of the case, I strongly recommend you do. It will really strengthen your base for beginning practice. Where are you in your program at the moment?
Actually, I this is my 2nd year of my master degree.
Mm-hmm. So you're about to go into clinical placement?
Yes.
Fantastic. These cases are excellent for preparing you for clinical placement, because you'll see in a moment that we're working with a real life patient. So wherever we can, we've incorporated the stories and the histories of real life patients, and we've provided videos for you to look at of those patients. So here we have Mr. Robertson, and he is a 65-year-old retired gentleman. He lives with his wife. And what I would recommend you do at this point is start to keep in mind the nutrition care process and the information that you'll be gathering in your assessment with this patient. So I want you to pretend here that you're actually in the room with the patient, and you're starting to write down the information that you need as a dietitian to impact the way he is behaving in his life. And obviously the things that he's doing around food and exercise are leading to him gaining weight over time. So pull out of all of this information what you think you're going to need to know to work with him. While he was in the workforce, he had a job as a construction overseer, and he was active in that role for several times a day. But since he's retired, his activity levels have really dropped, and he's adopted largely a sedentary lifestyle. Now he's gone to see his family doctor, and the doctor has done a physical examination, Mr. Robertson thought he was in good health. He wants to remain in good health. He gave up smoking 20 years ago. His father died from an MI at age 55. So what are we gathering here? You've got in the top, in the blue, you've started to take his social background. And then now we are moving into his medical background. And we're looking at family history. So you should have a section in your assessment called family history, and you are writing down. Actually, I'm going to show you something before I go any further, because it's going to help you a lot in what you're writing down when you begin your assessment of a patient. And I'm going to take you into the activities of the case. And I would recommend that you just go, you print a few copies of this and you have this handy whenever you are starting a new NC Pro case. Okay. Exercise 1.17 is a very important exercise for you. It teaches you how to write chart entries. And we give you templates. We give you the ADIME template, Assessment, Diagnosis, Intervention, Monitoring and Evaluation template, and we give you the SOAP template. The documentation is also available in the toolkit. So you can click on these links and it will show you the documentation. But what I'd like you to do is download and print, not right now, unless it's really handy to you, a few of these, and you'll be able to follow these when you are with your patients, your NC Pro patients. So you're beginning, it has a space for food and nutrition related history, for the anthropometric measures of the patient, the biochemical measures of the patient, your nutrition focused physical findings, and the client history. Now let's just keep all of those points in mind as we are going through the patient's story. Right, so you want his social background. You're going to gather that from there. We're moving into his medical background. So he's given up smoking. You're gathering information about the patient's family history. So he actually has a significant family history of MI, but also type 2 diabetes. Now, you can see from this patient by looking at his face, so you've started your physical focus findings right now, and you can see that he's carrying a lot of his weight in the upper part of his body. Have you opened into the case study under your names rather than just looking at what I have up here? If you have, you'll also see him sitting in these videos, and you'll be able to see, use these videos for your physical focused findings. Okay, so moving along, the doctor undertakes the examination. He discovers that his blood pressure is elevated at 129/81. It's not horrendous. It's a good time to capture that. So in the back of your mind as a dietitian, you're not only starting to treat adult weight management, you're starting to treat hypertension. His weight is 90 kilograms, and we will soon see that he is indeed overweight. And before he comes to see you, you have given your patient, and you would always do this if you were in private practice, you send your patient information and question sheets, and they will complete things like a diet history for you. And that's exactly what this patient has done. He's completed this diet history, and we can do a quick look at this and instantly see some of the problems that are leading to his weight issues. We can see his eating patterns over the weekend. Immediately, I see that he's not having a lot of vegetables, nor fruit for that matter. And in fact, the fruit that he's having up until the evening snack is in the form of orange juice. So not enough fruit, not enough vegetables. We get into this in much more detail, but this is just what you would be considering as you're looking at this information quickly. You can see he's having mixed nuts. What do we know about nuts? They're 50% fat, they're high in calories, they will contribute to weight gain. if the patient is not burning that energy. And then the patient also in the form should give you information about their knowledge. You would be asking that before you see them. And we know that the patient thinks he has only a basic knowledge of the health consequences of his condition, the benefit of making nutrition change. Really important to have an understanding of that with your patients. If your patient can see no benefit from making nutrition-related change, then it's important to understand that, to know how to couch your interventions with them. And your interventions will be very different for somebody who assumes that, as opposed to somebody who's on board and clearly sees the benefit of diet, nutrition, and exercise. Is he ready to make changes? He's a 6 out of 10. So it's your job to tip him up towards the 10, motivate him to make sure he really is ready to make those changes. How confident are you that you'll be able to make the changes? He's only 4. So you've got some hard work to do around this patient's psychology, and also around how to alter his diet in a way that he's actually going to want to continue with you. And one thing I would strongly recommend, this brings me to the point of the Nike tick, the Nike tick when it comes to weight loss. We know that 90% or more of patients who come to see dietitians and are all fired up to lose weight will, if they go on an energy deficit diet, reduce their weight in the first 6 months. And then in the next 5 years, their weight will go up and beyond where they were when they started with you. The research on this is very clear. So what is it about the 10% of people who lose their weight and keep it off in that 5-year period? One of the things that they're doing, there's a number of things that they're doing, and we'll talk about that, but one of the things they're doing is they're coming back to see their health professional on a regular basis. And, you know, the evidence says that they need to be seeing the dietitian around about 22 times. So it is I can tell you from 30 years of working as a dietitian, it is very difficult to have your patients come back routinely over and over and over again, unless you are talking that into your spiel with them, your counselling with them from the outset. They need to have an understanding of exactly what I've explained to you, the importance of that ongoing support and motivation, and they need to be clear on what you are going to be doing with them over a long period of time. If you just sit down with the patient in the first consultation and don't refer to your next consultation and what you'll be doing in 6 months' time and 12 months' time, very good chance you'll never see that patient again. So work that counselling information in from the outset. Alrighty, so back to our case, back to our story. So we can see his height is 175 centimeters. His weight is 90 kilograms. You measure his waist-hip ratio as 1, and his BMI is 29. Now, he's been enjoying his retirement. He loves spending time with family and friends. He's gaining weight. It's never been a problem before, so he doesn't actually understand how to adjust his diet to lose weight. And his wife does all the shopping. He goes with his wife, so he has an interest in the grocery shopping. But she does all the cooking, and he describes her cooking as, you know, she's able to make good basic meals. Recreationally, he does tours around his small garden, and he maintains a busy social life. So he does a bit of bowling, and afterwards he has tea and fruitcake. He bowls for about 60 minutes in total weekly. He walks for 30 minutes per week. He gardens for 15 minutes daily. So you can see that there is not a lot of physical activity there to burn any kilojoules, excess kilojoules. On Wednesdays, now here is his part of the enjoyment in his life. Here he goes to the cinema. He eats chocolate-coated ice cream. When he goes grocery shopping, he has a donut. On Saturday nights, he has a packet of chips. You know, there's a lot of discretionary foods through the course of the week there. and he also has some alcohol. So when you're on your own and you're doing your reading for this case, you can also take a look at these little vignettes, and they'll tell you a lot more about the patient that you can use when you're beginning your activities. Now, here is a complex, a detailed review of the patient's diet. And this is the information that you're going to use when you come to do the activity 1.3. Riley, that's where we're heading next. And I'm going to show you how to calculate the protein in the food that your patient is having. So here's his diet history. Jessie, for your sake, he's having, Riley's very familiar with this diet history by now. A couple of slices of white toast, they're buttered, jam, egg, and orange juice and a coffee for Monday to Saturday. On Sunday, he's got the bacon and eggs. He's got coffee every day at morning tea time. Midday meal is just a ham and tomato sandwich. Every day he's having shortbread or a cookie, cream-filled cookie, and coffee in the afternoon, more sugar. And then evening meals are either steak or roast or a spaghetti bolognese. That's the kind of thing with these extra discretionary foods down here, the shortbread, the ice cream, the chips, the crisps, and the alcohol, the mixed nuts going in as well. So it's pretty clear for the dietitian to see the kinds of adjustments that need to be made. But that, as you know, is only at the very start of the picture. You know, you could go in full throttle and say, okay, we need to cut out the occasional foods that you can now see on your screen on the right-hand side. But that's not going to make him very happy, and you're probably never going to see him again. So it's how are you going to encourage him to reduce his overall intake enough that he can also enjoy his life? And what we would do in this case is not worry about weight loss straight away. We would go into full weight maintenance mode. Just weight maintenance. Let's try and prevent any more weight gain and hold him at 90 kilograms and let the body adjust to that for a period of time. The next time we see him, we're going to start the weight loss journey, if we can, if he's willing. All right, so Riley knows where the answers to the activities are. Jess, there's up to 22 activities in our cases. They take you through the ADIME process in a huge amount of detail. Once you've done 3 or 4 of these cases, you will know assessment, diagnosis, intervention, monitoring, and evaluation backwards. And you will get faster as time goes on at doing your assessments and your diagnoses and your interventions. But for the beginning, for this very first case, it'll take you some time to work your way through it. That's a good thing. Okay, so here are your activities. And right at the very bottom of this activity page, you're going to find your answer guide. And that's where I'm going to go straight into the answer guide now. Can you see this clearly on your screen? Are we okay?
Yes.
Yes.
Great. Now, we saw what your patient was eating. This form, Jessie, when you open it, of course, is blank. You are going to be entering all of this information in the form. Actually, I'm going to have to go back to the, sorry, here we go. Oh no, here we are. Yeah, so all of these numbers will not be present when you open this form for the first time. And it's up to you to complete the form and enter these numbers according to the number of food servings that your patient is having each day. So we know he is having in the mornings for breakfast. We saw in his diet history, he's having 2 slices of white toast. Now that is 2 grain and cereal servings. Have you both memorized your food serving sizes from the Australian Dietary Guidelines?
Not yet.
Okay, we are going to commit these to memory now. This is one of the most important things that you can do as a dietitian. You will never be able to analyze a diet in under 10 minutes, which is what you have to be able to do, unless you do this memory work early, okay? So I'm now Jess, I've gone into the toolkit. I've clicked toolkit for ready reckoners. I'm going down here to the Australian Dietary Guidelines. I'm going to have to go in a different way. All right. So the first thing that you need to know is the recommended average number of servings from each of the 5 food groups that people of different age groups in our demographic need to have on a daily basis. Now, your patient is 65 years old, so he's in this row here. Every day, he needs to have 5.5 servings of vegetables. What is a serving of vegetables? So I'd like you to write this down. It is 1/2 cup of cooked or 1 cup of raw vegetables. So he needs to have roughly 3 cups of cooked vegetables or 5.5 cups of raw vegetables every single day. And if you think back to his diet history, he's not having anywhere near that. He's having about 1/2 serve of tomato at lunchtime, and he's having maybe, I don't know, a cup at night. So we have to work on that. The next thing you have to memorize is that people of his demographic need two servings of fruit a day. And it's a serving size is 1/2 glass of juice, or it's a piece of fruit about that size. So it's an orange, an apple, a pear, a small banana, not a large Cavendish, maybe something more like a little lady finger. Or it's 1/2 to 1 cup of fruit salad, depending on the kind of fruit salad. With the grains, so the grains are all of your breads and cereals. And 1 slice of bread is equivalent to, so 15 to 20 grams of bread in any form. Doesn't matter if it's, you know, a flat bread or a bread roll. 15 to 20 grams is 1 serving. When it comes to rice and pasta, it depends on the pasta. 1/3 of a cup of a small pasta packed into the cup is 1 serving. But if you've got something like a big spiral, it would be more like half a cup. Rice, it's 1/3 of a cup is 1 serving. Have you encountered this before? I mean, you've both been studying nutrition for a long time. Have you encountered the serve sizes before?
Yeah, absolutely. Especially in just trying to create a balanced diet, obviously taking this into consideration is very important.
Yeah. Jessie, are you familiar with serve sizes?
Yes, but every time when I doing the radio reckoner, I will look at the guideline, so I can't memorize everything. So I think I need to memorize often.
You can't memorize it?
Yeah, it's a bit difficult for me to memorize this.
I see. Okay, it is just time. Remember how it was when you were learning your times tables? Oh my God, every day, over and over and over in grade 3. That's what this is about. Every day, over and over and over. It needs to be second nature to you.
Yeah,
you can't practice effectively unless you have really bedded this information down. It'll slow you down.
Yeah.
So keep at it, okay? It's important. All right, dairy, you know that a cup of milk is 1 serve. a matchbox size of cheese is 1 serve, a tub of yogurt is 1 serve. Anything that gives you about 300 milligrams of calcium is a serve. The protein foods vary, we'll come to that, and then it's slightly different for women, it's certainly very different for children. Okay. And just in the toolkit, I want to show you this. Can you see the toolkit for the exchange lists when you are when you're in your case?
Yes.
Oh, beautiful. Oh, great, 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 great. I want to show you this. You come down to this nutrition composition of diabetic exchange lists here. And this gives you all of the exchanges for carbohydrates that we're talking about. So if we're talking about 1 serving size from the grain group, which they call the starchy food groups, you can see that in that 1 serving of starchy foods, it's not just carbohydrate, there's also protein, there's fat, and that's the energy content. Here's the fruit, and so forth. So you can refer back to this table to help you with your food analysis when you need to.
Rowan, just on that table,
Yeah.
I know you say there's always, everything's an estimate, and there is a few differences in the energies between different types of foods. I know you've got another one that's got, for example, starchy foods calories is 75 calories.
Yeah.
So which one would you recommend?
Which one would you use? Yeah, that's a really good question. So that the exchange list for diabetes has come out of America, and they use the 80 calories. That's just what they've decided to use. They've taken an average of a large number of exchanges, and they've come up with that. Other ready reckoners will use 75. And at the end of the process, it's really not going to make a whole lot of difference to your calorie reckoning. All right, you know, it might be out by 10%, but you're still going to get an excellent overall impression. You can make the decision which one you want to use. I personally use the one in the handbook of Clinical Nutrition and Dietetics. I find that the easiest one to use. But right across the board, all through the literature, you are going to find variations. Yeah. So if you want to go into the food exchange list in more detail, you can just click on this, and it's going to give you the serving sizes that we're talking about for a lot of the foods in the diet, listed in plenty of detail here. All right, and as Riley has pointed out, they're saying these are 80 calories, 15 grams of carbohydrate, 3 grams of protein, 1 gram of fat. But the serve sizes are the same serve sizes that we use in the Australian Dietary Guidelines, as it's the same as they use in America. It's all 15 grams of carbohydrate. And similarly, the serve sizes for fruits, for non-starchy vegetables, etc., they are all the same. So you can come through here and familiarise yourselves with these. Okay, any questions before we move on? The next thing we're going to do is analyse the diet. Okay. Alrighty, so we know that he's having 2 serves of grains at breakfast in the form of the toast. We put 2 in the column. He's having 4 teaspoons of butter. Now, is this going to let me move across the page? For some reason, it's not letting me move to the other side of the page. Hang on, I will reduce the size and see if that helps. There we go. This column here is the fats and oils column. And we're going to put 4 in this column here because he's having 4 teaspoons and every teaspoon is 1 serve. He's having jam and jelly 3 teaspoons. Every 1 teaspoon of jam and jelly is 1 serve. So you would put 3 teaspoons in that column. He's having 1 egg, which is 0.5 of a 60-gram meat serve. So 2 eggs are 1 serve of meat. Then the juice, he's having 1 cup, which is 2 fruits, because we know that half a cup is 1 serve, and so forth. And you go through that entire process, entering the number of serves that he's having from each of the food groups. So you're converting this information here, the ingredients of his diet, into the dietary guideline food serves. Was there something about that that you didn't quite get, Riley? Something about that process?
No, that was pretty clear. I think just referring back to the serving sizes and making sure you get it correct was the challenging part, but
yes.
Clear.
Okay. All right. Well, if that was a bit challenging, I'm going to continue this exercise and show you. Okay, so we're moving into lunch now, and at lunch he's having 2 slices of bread, so we know that's another 2 bread and cereal serves. We're going to put 2 in the column, 2 teaspoons of fat, 2 in the fat column. Ham, 40 grams. We know that a 60-gram serve is what we would say is 1 serve. 40 grams is, ham's a little bit different because it's a high fluid thing. And when you're looking in your toolkit, you're going to be able to see what a serving of ham is in terms of the dietary guidelines. You have to refer to your toolkit for that information. So it's 0.75. And then half a cup of tomato is half a vegetable serve. Then we've got his cookies, and that is 1 bread and cereal plus some sugar plus some fat. And then down into his evening meal, and not forgetting the sugars in his coffee. We're making a note of that. So 1 teaspoon of sugar is 1 serving that you're going to add to the discretionary food list here. And then he's having steak, 240 grams. Now we know that a 60-gram serve of steak is 1 serve, 240 is 4 serves, so we're putting 4 in the column here. Half a cup of broccoli, half a cup of carrot, and half a cup of potato. So that gives him 2 serves of vegetables here, and then he's having a starchy vegetable here. Now the program is going to do that calculation and add up those figures for you. It means that he ends up with 5 breads and cereals, and you're keeping in mind as his dietitian, the majority of that's come from white bread, which is not terribly nutritionally important. He's having 2 serves of fruit juice. Again, there's no fiber in that. So opportunities for fiber right there. If you change that white bread to multigrain bread, for example, and you use, say, Bergen, you'd have 15 grams of fiber as opposed to 5 grams of fiber from the white bread. If you changed his fruit juice, which has virtually 0 fiber, to 2 pieces of whole fruit, there's another 6 grams of fiber. Just in those small changes, you've almost got him to the recommended daily intake of fiber for the day. The starchy veg, he's having the potato, that's no problem, no comment about that. Low starch veggies, not nearly enough of that. He's only halfway there with his vegetable intake. He's having 1.5 serves of dairy. Now we know a man of his age needs 2.5 for the calcium, so we have to encourage him to have extra. What are the benefits of having extra dairy foods? We know that dairy foods, low-fat dairy foods, if there is a problem with weight or heart disease, we would be recommending low-fat. We know that they are cardioprotective. They actually help reduce hypertension. So be strongly encouraging him to increase his low-fat dairy food, not necessarily cheese, certainly not cheddar, which is rich in sodium. We're also we're going to try and influence him a little bit about his sodium intake, but certainly milk and yogurt, excellent. And then discretionary foods and this fats and oils. This is where he really blows out. So he's having a lot of fat coming from those mixed nuts. You know, there's 40 grams of fat right there from the mixed nuts. He's having a total of 20 servings or 20 teaspoons of fat a day, and he's having 8 teaspoons of sugar a day. So we are beginning to think about the gentle ways that we can get his weight to stabilize, not go on increasing. And there's lots of small changes that we can make in that diet to bring that about. But, you know, the changes really need to come from your patient. They're much more likely to be effective if your patient has suggested them. But you obviously need to know where you're heading with him. Here's a little brief Ready Reckoner down here. Riley, there's your 75. That's definitely, I mean, that is absolutely perfectly fine to use. That's good. 300 kilojoules, 15 grams of protein, of carbohydrate. So we have gone with 2 grams of protein as opposed to the American 3. And what we did was we analysed and averaged a couple of hundred foods from the breads and cereal group, and that was the result that we came up with. The American food chain may be slightly different, so they've come up with just a very slightly different result, and so forth through all of those. So this, you know, if you're looking to memorize a Ready Reckoner, this is a good one to memorize. The one in the handbook is also a very good one to memorize. And then, so that is the process that we would do from Monday to Saturday. Then we do exactly the same thing for Sunday. We add those two together, and you need to take an average of the, actually what you do is take an average of the Monday to Saturday, add it to the Sunday, and take an average of those two. And the results that you would come up with would clearly show that his energy intake is in excess of what he requires. So his total protein intake a day is currently 121. Riley, we have estimated that he needs about 75 grams of protein a day, so he's over on his protein. He's over on his fat intake, and certainly the kind of fats that he's having are not the way we want to continue. There's his carbohydrate intake at 192 grams, and there is his energy intake at 12,857 kilojoules. So our next job is to calculate, and this is what you would be doing in your assessment of this patient, to calculate, well, we do a quick comparison against the dietary guidelines. So we find out what he's short in, and we can see that while his intake of grain foods is acceptable, it's not whole grain. Similarly, while his intake of fruits is acceptable, they're not whole fruits. His vegetable intake is low, dairy intake is low, meat intake is too high, fat intake is too high, sweets and alternative intake is too high against the dietary guidelines. Okay, you can have a read through this at your leisure. Just rolling along, we would plot the patient's BMI, and we know this is where he was when he wasn't gaining weight. He's come all the way up here now that he has gained weight. So he's in the overweight category. He's not yet in the obese category, but he's certainly moving in that direction. Okay, Riley and I have spent quite a lot of time on the estimating energy and protein needs. Jess, I'm just going to take you through this very quickly. We show 3 ways of estimating energy and protein so that you have a comparison of the results. We show the simple ratio method where you use kilograms of body weight. We use the Mifflin-St. Jeor, and we use the weight change assessment. So we using the difference. I would say if you are familiar with the Mifflin-St. or the simple ratio, go that way. Really easy to do. And the Mifflin-St. is proven to be a reliable tool for both healthy people and those who are overweight. Have you done a lot of work on the calculation of energy requirements in class?
Yes.
Oh, fantastic. Okay,
Yes.
well, we won't spend too much time on that there. We were talking earlier about his protein requirements. How much of that conversation did you catch, Jess?
I think, yeah, I think I almost get all the conversation you have just now with the Rayleigh about the protein.
Okay, fantastic. So we have elected to go with the upper end of the range of 0.8 to 1 gram of protein of adjusted body weight. And that brings us to, if we use his midpoint at 74, midpoint of the BMI at 74 kilograms, that means his protein intake is going to be 59 to 74, where we're going for the upper end of that. The Aspen guidelines are saying for people over 65, we need to go for 1 to 1.5 grams of protein a day. So we're going for the upper end of that. And as I mentioned earlier, if there's anything else that occurs with this patient, a morbidity of some kind or an increase in exercise, you would increase his protein accordingly. Okay. I'm not sure that we're going to have time. We're almost out of time this morning for evaluating the impact of physical activity. It's an interesting exercise I'd encourage you to do alone. Assessing the knowledge, beliefs, and attitudes of the patient, you're going to glean a lot of information from those little videos about your patient's knowledge, beliefs, and attitudes. And you're going to be understanding what's holding him back from losing weight and what is propelling him forward. And so one of the resources that you're going to use to give you that information is the sheet that the patient filled out before the consultation. And it's going to give you an indication that he was sitting at kind of 4 out of 7 and 6 out of 10 on most of those questions we posed about his knowledge, his belief about health, his willingness to change. So when you're running your assessment, you're making notes about his knowledge, beliefs, and attitudes, and you're thinking about how that's going to impact your intervention strategies. So he states that he is not knowing where to start. That obviously reflects his knowledge and also his feeling that he's a little overwhelmed. He just doesn't know what to do. He's looking to you for very clear, simple instruction. He hasn't made any statement indicating whether he does or does not know that what he eats is related to his weight gain. We're unsure about that. He's stated that he's a little worried due to his family history. That's a good thing for you. He recognizes his family history is a concern, and that will propel him forward. His self-rating was 6 for the likelihood of having nutrition-related problems. His statement about being a little worried does not tell you how much he really knows about the severity of his risk to health caused by weight gain. So he was at a self-rating of 4 on a scale of 1 to 7 for the perceived severity of risk to health. So you now know that it's your job to describe that diet-disease relationship very, very carefully. If you'd been speaking with a cardiothoracic surgeon who had a very clear understanding of dietary intake and say hypertension, coronary heart disease, you wouldn't have to spend much time on that story. But for this patient, absolutely. The next question is his perceived benefit of nutrition-related change. Does he actually think that diet will change his health? And his perceived benefit score was a 4. He's midway. He's not actually sure if it's going to make terribly much difference. So again, it's your job to convince him that it will. And then finally, his readiness to change. And this is a really important one for you. He's only at the point of just considering whether he's ready to start these changes. He's made the effort of going to the doctor. He's made the effort of going to the dietitian. Now it's up to you to really motivate him, get him over the edge so that he's no longer considering, he's fully committed. And the last one is he able to use social networks to support his behaviour? We're not too sure about the support of his wife. I would definitely try and encourage his wife to come to one of these consultations, given that she's involved in the shopping and the cooking. And he's not really shared terribly much information about his social networks. So we can work on that perhaps at the next consultation with him. All right, so your next job would be to summarise the nutrition assessment. And here is what I would expect you to have in your chart entry information. All right, so you would have done a quick calculation of his energy and protein intake. You would have in your mind a calculation of his sodium intake, and you learn how to do sodium assessment in the hypertension case. You would also have a comparison of his intake against the Australian dietary guidelines. The estimated servings per day are listed in this table here. You would have a record of his alcohol intake. And this is all information that you store in your own electronic health record system for your patients, if you're in private practice, that is. Then, has he had any previous dietetic counselling? He has not. Most foods consumed with family or friends in a social setting. Here is an overview of his knowledge, beliefs and attitudes that we've already spent some time on. Here's an overview of his physical activity, not very much. There are his anthropometric measurements, 175, 90 kilograms, 12 kilogram weight gain in 6 months, half a kilogram a week, that works out to be. And then his BMI and the range that we're looking for his BMI is 21 to 27 kilograms per metre squared. Now, why, Jessie, you might be wondering why we have gone from 21 to 27. Do you know the answer to that rather than, 20 to 25? Do you know why we go higher?
Is it because of the adjusted body weight?
Because of no, it's actually because of the age of your patient. So patients who are over 65 years old, you use a higher BMI. There is longevity in being a little overweight when you get to 65 and older.
Yeah.
Nutrition-focused physical findings are here. We know he's carrying his weight in the upper part of his body, so you'd make a note of that. His clothes are tight, he needs larger sizes, his blood pressure is there, and so forth. Now, comparative standards. Have either of you done very much work on comparative standards in class?
No.
No for me.
Okay. All right. Well, hopefully you'll be covering that this year. So this is an overview of what your patient requires in terms of the key points that you're going to be changing in the diet. For this patient, you're going to be looking at his energy intake. You're going to be looking at his macronutrient intake, and in particular his protein intake, because we know from our assessment it's very high. If he were a diabetic, that would not be, well, it might be protein, but it's also going to be carbohydrate. If he was a patient with coronary heart disease and out of whack lipid profile, you'd be looking at fat there as well. The other thing that we're going to be looking at for this patient is weight and growth recommendations. Now, these are terms and codes that have come from the ENCPT. They're not something I've made up. They've come directly from the Academy of Nutrition and Dietetics, the terms and codes that we're using. So that is why it says weight and growth recommendations, not just weight recommendations. And we're going to be looking at his ideal reference body weight and his recommended body mass index. Now, this next column here gives you an opportunity to describe the system that you're going to be using to assess your patient's needs and requirements. So his total energy needs, you have used, in this case, the Mifflin St. George. You make a note of that. And the reason you do that is so that the next dietitian understands how you've come up with your calculations. You may never see this patient again. You may be handed over to somebody else. Providing this information helps the next person. Also helps you when you come back to see this patient again. Here's his protein requirements in 24 hours, 0.8 to 1 protein per kilogram of adjusted ideal body weight. The alternative is greater than 1 gram protein per kilogram of adjusted using the ESPN guidelines. And then his reference weight, midpoint of 74, and then his recommended body mass index, 64 to 83. Okay, so then I'm going to scroll straight down because we're really running out of time. We only have 5 minutes left. We're going to be having a look at the diagnosis of the patient. How are you going to diagnose him? Here's our diagnosis. Here we are. And usually it's not just one diagnosis that the dietitian comes up with because, you know, people are complex and we're not just looking at one of the domains associated with diagnosis. We will be looking at all of the domains and seeing whether any of them apply. So, you know, the first domain is intake. And when we're thinking about his intake domain, the first thing that jumps to mind is excessive energy intake. And his excessive energy intake is related to his snack and his drink consumption, particularly when he's socializing, and also the fact that he has a limited knowledge of energy-dense foods and beverages. And this is evidenced by his current energy intake of almost 13,000 kilojoules a day. And it's evidenced by the amount of occasional foods that he's having and also by his weight gain. So we must never write a PES statement without presenting the evidence. So, you know, I've seen PES statements come in where it would just say patient overweight as the evidence. Well, that's not sufficient. You need to be much more specific than that. And providing an indication of his energy intake along with as much other information as possible from your assessment helps the next dietitian. It also helps the other practitioners who are working with this patient. So that is one option that you could use. The next option is overweight, related to frequent intake of energy-dense foods and reduced activity, as evidenced by BMI of 29.4. That's fair enough. The next one is physical inactivity, and that's related to retirement and a lack of awareness, and then that's evidenced by the amount of activity he's doing each week. The next one is undesirable food choices. No previous need to restrict calories, increase social activities during retirement, and the evidence is there. It's a low intake of vegetables, fruit, dairy, 5 to 7 servings of occasional foods when compared to the national dietary guidelines. And then the final one is that he's not ready for diet and lifestyle change. And this is a really, really important one for the dietitian to consider. And sometimes, while we are encouraged to use intake diagnosis as our first port of call, sometimes it's not relevant enough. And we need to look at the patient's psychology and use that as the basis of our PES statement. And in this instance, this is a very important PES statement. The patient simply isn't ready yet. So when you're thinking about your interventions, you're thinking, what is going to make the most difference to this patient? Is it that I just go in and reduce his energy content, which would certainly feed into the very first PES statement we looked at, excess energy? Or is it that I feed into his psychology and try and work with his motivation? What's going to be better for this patient? So let's see. The way that you would determine what's going to be better is that you can use these little checkpoints. The first thing that you would say is, can the dietitian resolve the nutrition diagnosis? And in each one of those cases, the dietitian can. If deciding between two diagnoses that describes the situation in different ways, aim to select as your first preference the one that belongs to the intake domain. Is the etiology the root cause or the real cause of the problem? Will measuring the signs and symptoms tell you that the problem is resolved? That's important. And then, are the signs and symptoms specific enough that they can be measured? That's another reason for putting in really good signs and symptoms. You've got to be able to measure them over time. And putting in, because the patient, as evidenced by patient overweight, that is just simply not enough evidence. So, okay, give me your feedback here. Which do you think is going to be the best diagnosis for this patient based on those criteria?
I think it's the overeating, the first one.
First one, yep, that is definitely valid. What about you? Riley, what do you think?
Not too sure exactly. I'm just tuning in.
No, it's tricky. And I think we can go with both of them. I think that we can incorporate both. I think you need to be working to reduce his energy intake in that first consultation, and you also need to be working closely with the fellow's psychology to motivate him and move him to the next stage of change. No harm in having two. All righty, so now we move into interventions. I'm going to have to close it here. I've got patients coming in now. I have a couple of minutes for questions if anybody has anything that they'd like to raise just quickly at this point.
That's been pretty clear. It's great. Thank you.
Oh, you're very welcome. Nothing from you, Jessie?
Yeah, no question for me as well. That's very clear. Thank you.
Okay, terrific. So the next step is for you to just work through the interventions for the patient, see what the dietitian has selected for the patient and how they have decided on those decisions. And the monitoring and evaluation part is super easy. That won't take you very long to do. All righty, so next week I don't think I've got a session on, but I'm pretty sure I'm back the following week. And I don't know if you've booked in for anything. I know that we're starting to do some sessions outside of the cases on ready reckoners and dietary analysis and a whole bunch of other stuff. So I hope you can join for those in future.
Yes, so will they just be emailed to us, those other events that'll be happening, just so we can
Schedule it?
Schedule it?
Yeah, one hour, just over an hour usually.
Yep.
Yep. All righty, well, we'll leave you to enjoy your day. Thanks very much for popping in this morning. It's great to see you both.
Thank you very much.
Okay, see you later.